Okay, we're ready to get started now with the evening session. We would like to thank Medico Incorporated for their lunch. Hope everybody enjoyed the lunch. Please give them a round of applause, please. Thank you. Our next speaker is Mr. Nelson Smith. He's Commissioner, Virginia Department of Behavioral Health and Development Services. Mr. Smith was appointed Commissioner of Virginia Department of Behavioral Health and Developmental Service by Governor Glenn Youngkin. And we're hoping today that he's going to fix all our TDO problems by next week there. So come on up, sir.
All right, no pressure. Next Tuesday, right? Well, I can tell you, I think the governor pretty much said it all. So, any questions? No, one of the things I think we can all agree on is having the support of someone like that. I can tell you, that's the only reason why I volunteered to do this job, was to follow someone who is all about getting things done and swing for the fences. That's what he always tells us. So again, he alluded to the fact that we don't have a magic wand or some sort of magic bullet to solve this overnight. We are looking at interim, like near-term wins. What can we do right now to alleviate that pressure? And then some of the things that we're doing interim, midterm, and long-term to transform the entirety of the system. What we don't want to do is to Band-Aid these things. There's been a lot of initiatives that we're wasting Virginians' taxpayer dollars, our taxpayer dollars, to do these little Band-Aids at a scale of millions. One program is this, piloting that. And so we're really looking at the continuum of what does that journey look like for a Virginian? From the time that they need some sort of help or therapy to post-discharge, all the way for housing and community supports. So again, it's going to take some time, and jokingly, whoever takes over in the next administration is going to be set up for success for the long-term care, right? So again, there is going to be some really good things that are coming. So I'm going to give you sort of like an overarching, I guess, where we are right now and some of the ways that we think, so at least you can get the sense of where we're going. So when I inherited the agency, there was no strategic plan. And so without that, how would the community know which direction we were going to go? I mean, so we came with this idea of the North Star. It kind of guides, it's always guided us. And so from that, as I developed these conversations, I've been traveling around the entirety of the state. I wanted to hear from everyone, and I've probably been to most of your communities, been burning the roads up. So out of that came, a lot of glaring things that are just common sense. I often ask, does it make sense? If it doesn't make sense, then why are we doing it? If it does, let's do it. And so these are the three big objectives that we're going to be working on. I know you're feeling the squeeze, right? We've been feeling this squeeze for years. So again, just as we work through these things, just know that we will be alleviating these pressures. So I can tell you, so far this year, we've been able to open up over 130 beds. I think it's closer to 140 in the state facilities. But I am committed to opening up almost all the beds. I would say all the beds. You can't hold me. I'm gunning for it by 2023. So when I inherited the agency, we had almost a 40% vacancy rate. I'd say 38+%. We're down to at least 30% now in the past couple of months. So we've been able to reduce those vacancies by 8%. That's still just shy of 1,000 people short to staff these beds. And we're charged with treating people, like giving them the best options for their sickness. So it's not like you can just put them in a room and hold them there. We have to give them therapies and help them get back into their communities. I can tell you that forensics, take up about 60% of our hospital beds. So those are the ones that are court mandated for whatever reasons that go there. So we all know workforce is a big issue. So that's one of the big, if you notice, the North Star was kind of in the middle of all of those little circles. The workforce, they all intertwine with one another. So our workforce is going to be one of our biggest things that we're working on. So this gives you a general flow of like the idea of a good system. Again, we want to open up all the beds, but that's not going to be the only thing that's going to solve this problem. Let's say we open up all the beds. Well, we had them open a few years ago, right? And we still had the same problems. So it's estimated that 96% of individuals who receive direct referrals to a crisis provider do not require an emergency room visit. People who get someone on a phone, they need someone to call, whether it's crisis or whether they're trying to prevent a crisis, are part of that number. So the point is that right now we don't have some of those intermediaries. It's either an all or nothing situation, emergency room or nothing. So I'm going to go into more details of what we're going to do to fill in those blanks. This is just something to consider. As you all know, back in 2014, we had some legislation that put us into this bed of last resort. These highlight some of the unintended consequences. As we know, the spirit of it was intended to make sure that there's a safety net for human beings, for our Virginians, a place for them to go to get treatment. Unfortunately, it's increased massive increases in our TDO admissions to the hospitals, state hospitals, that is, specifically. You were already experiencing longer wait times before the pandemic, but now it's gotten even worse. So I'd say the average, I was just talking about this, the average wait time for law enforcement is about 43.7 hours throughout the state of Virginia. That's an entire work week. And that's plus or minus a couple of days on both sides of that, not to mention the human being that's sitting there without treatment. So the overpopulation has been burdening everyone, our citizens, CSBs, staff, private hospitals. And we're also still seeing loss of custody. That's still happening. The streeting effect that was the fear before is still happening at scale. And we're never going to get out of this cycle without addressing this legislation to some degree. So here's what we're going to do, and hopefully get your support in this. These are some of the things the governor mentioned. These are going to be some of these near-term situations. Last session, there was legislation that would allow alternative custody providers to take custody of individuals under a TDO. I can tell you my experience in traveling the state and listening to all of you is the fact that transportation isn't the biggest issue. If we can get you out of sitting in the emergency rooms and get you back into those communities, then I think we'll be in better shape. Now, of course, to me, that's the near term, is who can take custody. It doesn't need to be law enforcement. I mean, you guys are already everything to everybody in your communities, and now you're mental health providers too. So again, to me, the focus, and as the governor alluded to, you didn't hear him say transportation. It was custody. That's what we're going to focus on right now. And then we'll get to that transportation. I'm not saying we're forgetting about that altogether. So I asked our staff to develop a program right now. It's rolled out in the Southwest. It's piloting. It's one of those Band-Aids. We started with those localities where they have to travel 8 to 10 hours sometimes to transport a patient. They don't have a lot of people in those agencies, so we're rolling it out there with the option to expand that into the future if need be, but that's not going to be the answer. It's just to reduce these solutions. So Senator Newman introduced a bill that required a work group to expand alternative custody concepts and look at our bed capacity. And so as the governor mentioned, we've been working on that for the past few months. It has stakeholders from all over the state of Virginia and representatives of different agencies. And the meetings have been public, and our recommendations are going to be sent to the General Assembly by October 1st. Again, those recommendations as the governor alluded to, are going to be, I hope, focused on custody situations. So the vision of where we're going to go. For several years, we've been building a comprehensive crisis service that meets the needs of our community. This includes crisis stabilization, mobile crisis, and some of these dispatch centers. As you know, 988 was rolled out here nationwide, actually. The reason that we're not really pushing that incredibly hard right now is like 911. If any of you remember how that was rolled out, it was incremental over time. We don't want to burden the system. We have to have those supports in place. There are some areas of Virginia that have those mobile crises, and the people to respond to these to these crises, they're more robust than others. So again, if we overburden the system right now, then we won't have the pieces in place to respond to these people who need help. Ultimately, it's going to divert the calls away from 911. There was a place in Virginia, or is it Highlands? Forgive me, I've been going all over the place. A really good example of one that was off the ground. There's a co-response unit that in some of these other areas that I've seen also, but they have clinical teams that are dispatched to these calls. One of the clinicians was actually wearing this teal body armor. They were very excited about that. Hopefully he didn't have to use it, which is what I told them. Body armor is for a purpose. But they were very excited. And these programs that are actually I'll get to that, is the effectiveness of them. So the CRCs, actually the governor mentioned this too. These are big components of what we're going to be doing. This is going to be those midterm, because to build these things out, it takes about a year and a half, if we get the funding to build more of them. So this is the third piece of our crisis system. You know them as CTACs or CSUs or 23-hour observations. The idea is to have a place for law enforcement to bring a patient or a Virginian in need where they can get seen and get evaluated and receive some sort of care immediately. It'll be staffed with therapists, nurses, with the medical telehealth available at those locations. And again, many of these places are already operating. So together with mobile crisis, CSUs, all of these things, this is going to help alleviate some of these crisis situations, and actually the census situation that we have in the facilities. The key is to de-escalate and connect people to the services that they need. De-escalation, again, is like 988. If you call and they have someone to talk to, the idea is that they'll be able to talk down. So this is the biggest so what to this slide, for me, this whole situation. This is the goal. This is what we're going for. Now, it's very simple. When the system is fully built, over 80% of those calls, and I can tell you we're currently receiving over 5,000, upwards of 6,000 calls per month on our 988 crisis lines. As a matter of fact, Virginia is actually leading the way with our 988 call center. The federal government has said we need to answer at least 90% of our calls by 2023. We're already doing that. The other supports that go behind that, we're still trying to build out, the crisis receiving centers and the mobile crisis. But again, 80% of these calls are resolved on the line. Of the remaining 20%, fully developed mobile crisis teams will be able to address those in the community 70% of the time. This is a lot of people that will not be ECO'd. I just want to pause on that one for a minute because, again, this is what we're gunning for. All right, so we know that there are still going to be people that will need help, but if you understand, like as this continues in this perfect system, we're not going to have a bed crisis. We'll have plenty of space for them. There are likely some ways we can help the private emergency rooms to be part of the solution as well. Further limiting your duties to sit in those facilities. So I think you can see there are a lot of possibilities. We talked about also special conservators of the peace, working with some of the private hospitals. to see if we can get some sort of custody situation in place. That's another near-term thing that we're talking about. So this gives you a kind of a map to where the current sites are. And you can see there are some gaps. Again, the crisis receiving centers, those are the ones that are in blue. There aren't many of them. I can tell you that we have a budget amendment going in that's going to give us the ability to fill in a lot of those gaps. That's going to take, again, about 1.5 years. That's from the time that we get the money to do that. So, if you haven't been out and seen some of these locations, I encourage you to go and visit some of these CRCs. And if you have one in your area, share that information, because I think that'll give everyone a better sense of where we're going. So this slide will help you see some of the path when it comes to the alternative custody and transportation meeting. I said 1.5 years. It takes about 9 to 12 months after receiving the appropriations to build one out. That's if everything goes well. The administration and my agency and the work group are aware that you need these solutions right now. So we're going to be working really hard to get some of those short-term things in place. Maybe not too far in the future, but maybe 12 to 24 months, we're going to have more solutions for how the facilities can be added to take custody, which is not just law enforcement, which I already spoke to. And as mentioned earlier, we're going to be reopening those beds, and hopefully private hospitals will be working hard to reopen their beds too. They also are facing psychiatric bed challenges. They don't have staffing as well. So the build out of that full crisis continuum is the ultimate goal. And then the custody issues and all the near-term things that we're doing in between is going to be some of those Band-Aid things, targeting to alleviate those pressures sooner rather than later. So I know that's not a lot of detail. It's not a magic bullet, but it's, I think, better than we were. Now, in amongst all of this, as the governor alluded to, not even what he mentioned was the fact that we're actually going through a whole systems redesign. That in itself is a huge lift. We want to fix this for the long term. And so we're looking at the best in class in other states. If this is going to be the best state to live, work, and raise a family, and the safest, we also have to have a mental health care system that is best in class too. So the commitment is there, the support is there, and we're on the job to get it done. So I'd be happy to take any questions. All right. I thought I'd have at least one. Well, no, I thank you for all you're doing. I echo what the governor said. You're in the fight every day, and we are committed to getting you back out there and to get our Virginians the treatment they deserve and they need. So I'm honored to be here. Thank you very much. Yeah.
Okay, Mr. Smith, again, thank you so much for the information there. We appreciate you coming out, being with us today. Our next speaker would be Mr. Mason Byrd. He's a Chief Deputy Director of Virginia Department of Forensic Science. Mr. Byrd began serving in May 2022 as Chief Deputy, Virginia Department of Forensic Science after a career in law enforcement and serving as an attorney in various capacities in state government. Mr. Byrd.
Good afternoon. We're happy to be here to share some information from the Department of Forensic Science. First off, I'd like to announce we're in the plans of building a new central laboratory. It's going to be in Hanover County. So the parking problems that people have had associated with coming to downtown Richmond to drop off evidence, those will be alleviated. It's right near the Richmond Times-Dispatch property, if you're familiar with that, so it should be easy on and off access to 295 and to I-95. We're hoping to break ground in December. We have some budget issues to overcome. All of you that have had large budget items, in the works for some time have noticed that prices are going up. So we have to have some things reapproved, but we're looking forward to that. As you know, the Office of the Chief Medical Examiner in all 4 of our laboratories is co-located as well. So the photo you see on the right, that's our new building. Worked with the architects last week. It's going to be an amazing facility for both OCME and DFS. And before I forget, hot off the press, they shared some information with us last week, and we sent it out to law enforcement agencies in a letter about a problem that we're having with supply chains. You heard early on in the pandemic there was an issue with a lot of folks with swabs. Well, now our latest issue that we're having is with the gray tops. In DUID kits, we have the blood specimen collection units, and they have gray top containers on them. I don't know a whole lot about the science, but apparently what is inside those test tubes is very particular, and the code requires them to go through us for approval. Well, our recent order of 10,000, they notified us that we will be receiving 500 of the 10,000. So we're working with the vendors, trying to figure out what to do, but apparently this problem is not going to go away. I understand there are supply chain problems everywhere. I understand it's hard getting Ford vehicles, for one, that I've heard quite a bit from law enforcement agencies. So what we're asking you to do with this issue is to inventory what DUID kits you have. Back when I was a cop, sometimes when we had a take-home car, we'd grab a little bit of extra everything and throw it in the trunk. So if you could do an inventory for your agencies, ask everybody to check and let you know what unexpired DUID kits you have. Please do that as a first step. Limit who gets them, and we'll continue working. If you have further questions, at whichever lab you have, either Norfolk, Roanoke, Manassas, or Richmond, if you have further questions about it, get with the folks at the evidence submission area. They'll have further information, but we're working on that right now. We understand that's a huge issue for DUID enforcement. So one of the issues we wanted to update you on is some legislation from last year on the PERC tracking system. So the physical evidence recovery kits, there's been legislation in effect for a number of years now where once the PERC comes to us from the manufacturer, we put it in a tracking system, and then when we send it to the hospital or to a law enforcement agency, whoever receives it updates it. And the idea is wherever that PERC is, we have a PERC tracking system coordinator at DFS that can identify exactly where that PERC is. So once it goes to the hospital, if law enforcement picks it up from the hospital will show that it went to law enforcement, and if we haven't gotten it in a while, we know exactly who to contact. It's so that we don't have the problems that we've experienced in the past. Well, one of the things that they've added in the last General Assembly session is a mandatory retention period for all PERCs. So previously, the statute covered after we did our analysis and we sent the PERC back to law enforcement, you had to retain it for a period of 10 years. Now law enforcement has to retain PERCs for a period of 10 years, whether or not you sent it to DFS for further analysis. So there's 5 different possibilities of why a PERC would not come to DFS. And the first one is it's an anonymous kit. So that's where the victim goes to the hospital, doesn't contact law enforcement, and they collect the PERC and they send it to the Department of Consolidated Laboratory Services just to store it. You wouldn't even know about it, not your problem. The next is where it's collected by the OCME as part of a routine death investigation. OCME contacts law enforcement and says, yeah, we don't think this needs to go for analysis. Law enforcement agrees. We don't get it. That now needs to be stored for a period of 10 years. It's connected to an out-of-state offense. You transfer that PERC to the out-of-state agency, and they'd have responsibility for further analysis. One that we see with some regularity is that your law enforcement agency has determined through its initial investigation that the collection of the PERC at the hospital wasn't connected to a criminal offense. And if you determine that it's not connected to a criminal offense, you don't need to send it to DFS. But now, under the new statute, you still need to retain that perk for a period of 10 years. If you've received a perk from the hospital, but you determine that the offense occurred in another agency's jurisdiction within Virginia, you're going to transfer that kit to that other agency, who's then going to submit it to DFS. So now where does the law stand? The law stands now that if a perk is collected, it's going to be stored for a minimum of 10 years, whether we've had analysis of it at DFS or you've retained custody of it at the law enforcement agency. I kind of point out in red where you do the initial investigation and you determine that it's not connected to a criminal offense. We're not getting it, you're keeping it, but you still need to store that for 10 years. You know, the initial thought process was, well, it's not connected to a crime, it's not evidence, why do we need to store it? The General Assembly has come back and said, no, let's keep those kits for a minimum of 10 years. I guess it's just in case, you never know. There was also a change to the perk tracking system statutes relating to the victim's ability to get information from the system. And so the amendment last year, 19.2.11.11, requires law enforcement to provide the victim, the parent or guardian, if the victim is a minor, or the person's next of kin, with the perk ID number. There's an ID number on each kit, and a victim PIN. That gives the victim the ability to go into our system and see where the perk is. Doesn't give information about the investigation itself, it just merely tracks where that perk is. As the slide points out, you don't have to give the perk ID if doing so would interfere with an investigation or a prosecution of the offense. You don't have to give it. What you do need to tell the victim, though, is an anticipated date, if that's available, of when you'd be providing that to them. This is some new legislation from last year that we've put into effect working with some other agencies. We're calling it DBSATS. It's the DNA Data Bank Sample Tracking System. That was the best we could come up with, DBSATS. Actually, it was my boss, so we all agreed what a wonderful acronym that was. So DBSATS, in essence, just replaces what was the application in LIDS that law enforcement, courts, probation checked to see whether or not a DNA sample was in our database when someone is either arrested for a violent felony or they're convicted of a felony or one of the qualifying misdemeanor offenses. So we worked with the Comp Board and we worked heavily with DOC as well. DOC is a heavy user of the system to determine whether or not a DNA sample is in the system. The various statutes throughout the code, if a sample is required to be taken to put in the system, it's in a variety of sections, whether you're a probation officer, court, sheriff's office, or other regional jailer. It requires you to check first before you take a sample. They don't want you taking a sample if one already exists. So to effectuate that, we have the DBSAT system. And I'll go into it just a little bit more, but I was also asked to point out, sometimes we get requests to use DBSATs for something other than the purpose for which the statutes require it to be used. In other words, there's a law enforcement investigation. As part of your investigation, you want to know whether a DNA sample is in the system. DBSATs wasn't designed for that purpose. If you want to know just generally whether a DNA sample exists in our DNA database, there's a regulation that requires you just to send a letter to our data bank administrator, and we'll let you know whether a sample exists. So just to, you might ask, well, why does DFS have this now instead of Comp Board? Well, one thing, it's real time. We are the people who know what's in the data bank. We have the data bank. And so it's a real-time system. And probably the best feature, and I have previously collected DNA samples, and if any of you have done it, you know that the existing card that you fill out has the little blocks that you have to hand write the letters into, kind of like at the bank when they give you have to put it right in all your name and everything in there. Well, my handwriting wasn't always the best, and I always would misspell along the way and have to exit out. And you can just imagine the folks at the DNA data bank with this very important information trying to decipher our handwriting. We don't have the best handwriting. Well, we have what we are calling a pre-log system. So you can log on, see if somebody has a DNA sample in the database. If they don't, you collect the sample, and your officer right then and there can enter it into the DNA data bank. What is coming? There's a barcode on it, and so you can type it, fix it, make it just right before you hit enter. And then when the DNA sample is sent to DFS, once we collect it, we scan it, and the information is already in there. It's going to greatly reduce any problems deciphering to make sure that we get it right the first time. And as a matter of fact, if you find out that there's a problem with someone's previous entry when you're checking, there's a form that you can fill out, and we'll correct those as well. This was another letter that we sent out in May of 2022. You don't have to do anything with this. We just wanted to make sure that everybody was aware. So we have the 4 state labs that I previously mentioned, their areas that they serve. Well, we have a limited number of scientists that work particular areas, and none of us can ever guess exactly how many DNA cases we're going to have in one area versus DUID cases versus possession of cocaine or meth cases. And so our scientists are spread out at the 4 different labs. What we want to do to reduce problems with what we call turnaround time is to ensure that we're using our scientists to the greatest ability in the most effective, efficient manner that we can to get your evidence back to you timely. So when we see problems at one lab where they're backed up because they're all of a sudden getting a lot of DNA samples, we're transferring those DNA kits down to another lab. So if you're in Roanoke, it might go to Central, or it might go to the Eastern lab, and they will do the analysis there. And so you might be seeing some different names on the certificates of analysis than what you're familiar with. You don't have to worry about it. You don't have to do anything. You just submit it your normal means to your normal lab, and we'll make sure that it gets to the right place. But we also just want to have you be cognizant that when that person comes to testify, you might have somebody driving a long way before they get to court. And we're particularly mentioning this to the Commonwealth attorneys. It's more for them than for you all, but we wanted to share that with you. You don't have to do anything. You just submit it in your normal manner, and it will get there, and we'll have it tested in the most efficient, effective manner that we can. And other than that, if you do have any questions about the PERC tracking system, I have the general email address for our tracking coordinator there, and I'd be happy to take any questions if anybody has some questions. If not, I'll be standing around outside for a little bit too. You can meet me out there. Okay, thank you very much for having us.
Thank you, sir. We appreciate that information as always. Next speaker that we have today is the Local Choice Plan State Health Benefits Program, presented by Mr. Gary Johnson, Director of Office of Health Benefits, Virginia Department of Resource Management. Mr. Johnson is the Director of the Office of Health Benefits for the Virginia Department of Human Resources Management. Mr. Johnson, y'all, please join me.
Good afternoon, everybody. Hope everybody's having a nice day. We're going to switch gears a little bit here today. I know you guys are getting a lot of information here on law enforcement. I'm going to talk to you here probably for about 10, 15 minutes on healthcare. One of our favorite subjects is our healthcare administration. As you mentioned, my name's Gary Johnston. I run the Office of Health Benefits here for the Commonwealth of Virginia. Not sure if you guys are really all that concerned about my bio, but they did ask me to give a little background on myself. And before I get started, though, I do just want to say that I do appreciate and respect everything that law enforcement does for us. So I just want to say thank you for a job that you guys do well done. Thank you. As you can see, I was born and raised outside of Philadelphia. Try not to hold that against me. And yes, I am a diehard Eagles fan. So I moved here. I heard the boo. Now, wait, is this Commander country around here? Well, unfortunately, Wentz didn't look. Our retread quarterback that we didn't want didn't look too good on Sunday, but that's beside the point. I moved down here about 3 years ago to run the Office of Health Benefits here, and it's a great choice I made. I really enjoy working down here for the Commonwealth. I've been in healthcare and benefits now for, I hate to say, about a little over 30 years now, pretty much since college. I started out from the ground up, processing insurance claims, getting customer phone calls about issues that they're having with their claims. From there, I was a benefits consultant for Aon for a bunch of years, and I've headed up benefits for Philadelphia Coca-Cola, as well as MEI, a part of the very large Mars Candy Company. What we do in the Office of Health Benefits, we run all of the healthcare programs for all state and retired employees. That's probably about 130,000 employees, close to 260, 270,000 members. We also run, which I'm going to talk about today, which is why I'm down here, is the local choice health plan. And the local choice plan, it's available for all of the local municipalities as well as school districts here in the state of Virginia. It's an excellent program. I'm going to give you some more details here in some upcoming slides. We also run our line of duty act, which would be unfortunately for our policemen and firemen that get hurt in the line of duty. They're covered under a separate program called LODA. We also administer all the flexible spending accounts for the state. We have an on-site healthcare clinic that I run called Capital Square. And then some of the stuff, we make sure we comply with ACA. Most important, what we do here at OHB is we set all of the healthcare rates for the employers, for all the agencies, as well as for employees. That's not only for state employees, but under TLC as well as under LODA. That's one of our main jobs. We set all those contributions across the state. The local choice. It was actually established by the General Assembly in 1990. And it's governed by what we have it's the Code of Virginia, which actually sets all of the policy guidelines for us, whether it's for COVA or whether it's for TLC or LODA. They're all covered under the Code of Virginia. And it's managed through Office of Health Benefits, which is part of the Department of Human Resource Management. Some of the information here on TLC. We have over 360 groups that we cover. And that's across the state. And that's between municipalities as well as school districts. And we cover over 47,000 employees and 90,000 covered lives. Group size ranges from, as little as one up to about 1,500 employees. Big question, okay. Who's eligible? As I mentioned, counties, cities, towns, school boards, and the directing or governing body of any political entity and subdivision. So something to keep in mind here is I know I was very happy that the Virginia Sheriff's Association invited us down to talk to you guys. As an association, just the police or just fire cannot enter into the TLC program. It has to be something where your entire county or municipality has to decide to come under TLC. And some of the highlights, for it is there's no minimum participation required for members. The only requirement that we put on, and this would be actually on the municipality or the school board, is that in order to be eligible under the TLC program, your locality or your school district has to pay at least 80% of the costs, meaning that us as employees, we have to pay 20% or less, which actually it works out well for us. It works out well for the employees because it means your employers have to pay at least 80% of the actual cost. You can offer coverage for part-time employees, and then retiree coverage, again, that's subject to election by each of the municipalities or counties. There's a wide range of programs that we offer. We have about 5 different health programs to choose from, and they're all on a self-funded basis. You can see their Key Advantage Expanded, 250, 500, 100, as well as an HDHP program. We also have a couple of regional HMOs that we offer. One is Kaiser Permanente, as well as Optima Health. And they're fully insured programs, so total we offer about 7 different healthcare programs that each of the municipalities can choose from. Depending on the size of the municipality, generally we allow them to pick anywhere between 2, 3, or 4 different programs to offer out to their employees. And then also the retiree programs. The premiums, again, it's going to vary because there's a couple of big factors that vary when it comes to that. First off, it's going to, of course, your size, your demographics, as well as your claims history. How healthy of a group are you? So you can see there's a fairly wide range. Here's the main slide that I kind of wanted to get to, which is why to choose the local choice program. You can see there, over the last 5 years, our average rate changes have been less than 5%. National healthcare running right now probably about 6-7%, and we've had average increases of less than 5%. 99% of our groups renew every year, means they're very happy with the program that we offer. And the biggest thing, especially for a lot of the smaller school boards and municipalities, is that you have a much larger buying power. You're going to be pooling your monies together. Because now, instead of just being a small municipality that has 5 people, 10, 20, 30 people, you're part of a larger group that has 47,000 employees that all go together, and there's a pooling that goes together, and that's how we come up with the rates for everybody. Questions? Anybody at all? You can even ask me something about the Eagles. All right. Thank you. Yeah.
Who makes the decision whether a locality participates in that or not?
That, if it's a locality, because we run FSA programs for the state employees. So if whether or not your locality offers it, that would be something specific to your locality. Makes that decision. Yep. I assume you guys probably do not. Right. Yeah. Unfortunately, yeah. That's something that you would want to talk to your local HR about. Yep. Myself.
Put your information back up there?
Sure can.
No, it's
If you want, you can get me outside. I'll give you my information. All right. Any other questions? All right. Thank you.
Thank you, Mr. Johnson, for that information, sir. Okay, this time we will take a 30-minute break and be back at 3 o'clock. And I know everybody's probably eager to get out on the beach and enjoy the evening, but if you could come back to the next session, Mr. Grogan from the ATF, they're going to make a gun with a 3D printer. It's going to be very interesting. So please come back at 3 o'clock. Thank you.